Good morning, friends. Thanks, Dr. Vinay, for this opportunity. I would be talking to you on the anatomy and clinical assessment of the optic nerve fiber layer. Dr. Pandav has just explained you how to analyze the optic nerve head in the patient having glaucoma. Both are very important, the optic nerve and the RNFL, because the optic nerve is constituted by the RNFL, that is a retinal nerve fiber layer. How the nerve fiber layer derived? No, just I will not take much time in explaining you the anatomy of the RNFL, but I will tell you a very, very important and salient feature related to the anatomy of the RNFL. The important site for the glaucomatous damage is the neuronal cell or the ganglion cell. The ganglion cell is the inner layer of the retina. There are about 1.2 million ganglion cell or neuronal cell in the healthy subject, and almost 5,000 to 10,000 neuronal cell or the ganglion cell dies every year. And these neuronal cells, ganglion cells, they have an axon which forms the RNFL, the retinal nerve fiber layer, the innermost layer. After that is only the internal limiting layer. The retinal nerve fiber are the axons of these neuronal cells. They don't run to the optic nerve in the isolation. They run in the bundles. They form the bundles of around 20 to 25 fibers surrounded by the glial cells. And that's why they give appearance like white striations. You just see these pictures, so you would come to know that these are the axons, and from these, these are the ganglion cells, and from these ganglion cells, the axons are arising and they are moving towards the optic nerve. A very simple diagram. The inner layer of the retina, the neuronal cells, and they are moving towards the optic nerve in the forms of bundles. The most outer RNFL, they constitute the outer part of the disc, and the inner RNFL, which are from the arcuate area and the macular area, constitute the inner part of the optic nerve or the neuroretinal rim. Okay, so that is why it is most important, because in glaucoma, the central part of the neuronal cells are mostly affected. Almost 50% of the ganglion cells are present in the macular area, and a very least number are in the peripheral retina. That is what it is explained over here. If you see this, the neuronal cells, these fibers which are arising from the peripheral part are constituted the peripheral part of the neuroretinal rim, and the inner part, the most central part, constitute the inner part, and when they are lost, they form the notch in the optic disc, and that is what you can appreciate. They run towards the optic disc after their origination in a specific pattern that is called as an arcuate pattern. You can see that the superior temporal arcuate area, the inferior temporal, and from the nasal area, they run either in the arcuate fashion or the straight way as well. And that is why you get the arcuate scotoma when you perform the perimetry. All these layers you can see by doing the imaging technology, and I'm sure that Dr. Ronnie and Dr. Vinay are going to talk about that. But definitely you can see the RNFL and the neuronal cell layer on the OCT. Now let us go to the clinical aspect of the RNFL examination. The RNFL examination is a very, very critical part of the glaucoma, because all of us knows that the structural damage precedes the functional loss, and almost by 5 to 6 years. And just by doing the good thorough clinical examination, you can pick up the RNFL loss, and obviously that will be reflected on the perimetry. And if it is not reflected on the perimetry, it's a problem with the perimetry, not with your clinical examination. And whenever you are doing the RNFL analysis, make sure that you dilate the pupil. If your patient has a primary open angle glaucoma or a normal tension glaucoma, obviously you can dilate comfortably. And if the patient has an angle closure disease, then first do the prophylactic iridotomy and then dilate the pupil and do a thorough clinical examination of the optic nerve head and the RNFL. You can see over here, if you look carefully, that the inferior RNFL is thinned out. Same thing is over here. So as I said earlier, that the RNFL analysis represent the structural loss in the glaucoma, and which is preceded by the functional loss almost by 5 to 6 years, and that is all accepted by everyone. As I said earlier, the RNFL is composed of the ganglion cells, and they runs in the bundle of around 20 to 25 in number, surrounded by the astrocyte and the glial tissue. When you do the clinical examination of the RNFL, you must differentiate between the healthy RNFL and the pathological RNFL. The pathological RNFL represent in a various forms. The most important is a slit light defect, the wedge defect, and the diffuse loss. How to do the good clinical examination of the retinal nerve fiber layer? Obviously, you can use a direct ophthalmoscope, but that is not that great. The best thing is that you use a 78 or a 90 diopter lens and do with a slit lamp examination with a dilated pupil. Fundus camera is good for the documentation, and obviously you can do the imaging technology. You can use imaging technology like the HRT, OCT, and the GDX. That is how the healthy RNFL looks like. They appears like a thick white striations runs along with the retinal nerve fiber layers and converge towards the optic nerve head. That is again in the healthy subject, that is how the RNFL are converging over the optic nerve head. As I said earlier, you loses 5 to 10,000 ganglion cell every year, the normal individual. Obviously this process is accelerated if the patient has a disease like glaucoma. And when you loses a significant of the RNFL, then obviously by doing even the good clinical examination, you won't be able to pick up these white striation in the elderly people, particularly who has the atherosclerotic changes. So this patient does not have any glaucoma or any RNFL defect, but you cannot see a good white striation going towards the RNFL. That is what you do a good clinical examination, and you can pick up the RNFL defect. That is what Dr. Panda was explaining. This is a disc hemorrhage, splinter hemorrhage over the inferotemporal area, and along with that there is a RNFL defect, and there is a RNFL defect in the superior area as well. But when you do with a red-free light, why it is important to do a red-free light examination to assess the RNFL is that it has a lesser wavelength, and the lesser wavelength is scattered well in the superficial retina, and when they scattered well in the superficial retina, then you can do a good analysis of the superficial layer, and that is a RNFL. So always make sure that you see the RNFL with a red-free light also, and it's so prominently visible. You can see that in the previous photograph they were not so prominently visible, but when you do a red-free light examination, they are very prominently visible. You can see over here, though it's a small disc, otherwise if you have not dilated the pupil, so comfortably you can miss it out. But if once you dilate the pupil and you see it carefully, then you would be able to pick up the big wedge defect. Similarly over here, you can see that big wedge RNFL defect. Look at here. Primarily when you do a casual examination of the optic disc, you may feel that this patient has a glaucoma, but when you do a careful examination of the ONH and the RNFL, you will find that it is slightly obliquely inserted scleral canal, horizontally inserted scleral canal, and you can see that inferior conus, but all the RNFL converging towards the disc are very healthy. You can look around everywhere. So the good clinical examination of the optic nerve head and the RNFL can give you a good insight whether the patient has a glaucoma or does not have a glaucoma. Though some discs may mimic like a glaucoma, but they may not have a glaucoma. So as I said earlier, there are three specific patterns of the RNFL loss. One is the slit defect. You can pick up very comfortably, easily by doing the red-free photography. And as I said that when you see with the red-free light, you can prominently see this. You can visualize this is small RNFL splinter defect over here, and that is again visible on the clinical examination over here. Obviously, this patient when underwent a standard automated perimetry, that is white on white, there was no field defect. But obviously this patient has a glaucoma, otherwise from where this RNFL defect will appear. These are the example of the vase defect. You can see one large vase defect over here. There is another vase defect over here. There is a small vase defect over this area. Remaining area you can see a healthy white striations. You can see a healthy white striation. You can see a big vase defect over here. Again, the papillar macular bundle is pretty healthy. On the nasal side, again, it's pretty healthy. So by doing the good clinical examination of the disc and the RNFL, you would come to know that what kind of defect you can expect for the patient. Like in this patient, you can see that there is a diffuse generalized loss at the superior pole, and obviously this patient has a correlating inferior arcuate scotoma. So in summary, the good RNFL clinical examination is very critical. As Dr. Pandav said, the disc examination is very critical. So you cannot do the disc examination in isolation. You have to do a combined examination, that is disc and the RNFL, and the clinical examination of the RNFL cannot be substituted by the fancy equipments like the HRT, OCT and the GDX. The clinical examination is a true clinical examination and cannot be replaced by any other equipment. Usually the good clinical examination of the RNFL correlate well with the functional glaucomatous test. Thank you for your patience hearing. And I take this opportunity to invite all of you for the 26th annual meeting of the Glaucoma Society of India, going to be held in Palampur from 4 to 6 November 2016. Thank you.